our guru when it comes to deformity here at Penn. And then also three of our rockstar fellows. We have Matthew D'Ambrosio, Gabrielle Santangelo, and then Peter Zoe. And we'll be going through a few cases here. And so let me go ahead and share my screen, and we'll get things started here. Our case discussion tonight is going to center around acute on chronic cervical cases. Our goal here, honestly, was to kind of provide some interesting types of cases. Obviously, we've covered a lot of different topics over the course of the past couple of years. And our thought here was to kind of go through some things that might not have a right or wrong answer. Obviously, we have the advantage of getting to see these patients in our clinics or in the emergency department and really get to tease out some of the nuances that come with these pathologies. But truth be told, I think oftentimes we're still left scratching our heads trying to figure out what the right answer is for some of these complex issues. And obviously a forum like this lends itself to pretty interesting discussion, and I think hopefully we can provide some of that this evening. With that, I will turn it over to Matt, who is going to introduce our first case here. Matt.
Okay, thank you. And thank you for having us. See if I have control here. Perfect. All right, so the first patient we have, they're a 49-year-old right-hand dominant male with long-standing bilateral hand dexterity problems and a recent onset of right arm and hand weakness for the past 2 months. They deny any radiating or pain or numbness. Their weakness is most notable in the right biceps, and he works as a chef. He's kind of unable to carry more than 3 pounds and really struggles with that at work. Past medical history, not very significant. Hypertension, high cholesterol, diabetes with the most recent hemoglobin A1C of 6.9. At the time of presentation, he didn't really attempt any formal conservative treatments other than really rest. In fact, he's kind of been seen multiple times, and the patient opted to put off surgery due to obligations with his work. So he's kind of had these hand dexterity issues for a while. On exam, he has moderate to severe right triceps, biceps, and thenar atrophy. He has a positive Hoffman bilaterally and inverted brachioradialis reflex on the left. As far as his physical exam, it's unimpressive on the right. However, unimpressive on the left. However, on the right, he's got moderate to severe right triceps, biceps, and thenar atrophy. And kind of weakness all over that right side, kind of stemming from C5 all the way down in his biceps, triceps, elbow extension, and flexion. X-rays of the cervical spine demonstrate some degenerative changes. He does have congenital scoliosis, significantly at that 3-4 level and then at that 5-6 level as well. And then looking at his MRI, cervical spine, he has that congenital stenosis that you can see, severe central and foraminal stenosis at C3-4. And then looking down at C4-5, C5-6, there's severe foraminal stenosis. So focusing on kind of that upper right image, you can see the severe foraminal stenosis that seems to have prompted his kind of return to the office. Select CT cuts just show the facets on each right and left side, showing that there's no real fusion going on there. There's no signs of OPLL and don't really lend a whole lot else to the picture. Here you can see the 2 osteophytes at 3-4, degenerative changes at 5-6, and then no evidence of OPLL or anything like that. So to summarize, we have a 49-year-old male with myeloradiculopathy with associated muscle atrophy and weakness, kind of localized to that biceps muscle, which is kind of his most significant issue.
That's great, Matt. Maybe we'll take a pause there if you want to skip back a quick slide. And so, I'd be curious, Jens, to get your thoughts on this individual. So this is a gentleman that presented to my clinic. He's a very high-level chef, really kind of a long-standing history of some degree of what you would describe as upper motor neuron findings. But really, his biggest complaint that has him coming into the office is he's probably 2 out of 5 in his right bicep. And this is a new issue. So kind of a longstanding congenital stenotic type picture. And now all of a sudden, 2-month history of really right biceps weakness. And to the point now where, he's really having trouble with his job. And again, this is a guy who's 49, he's very active. He's on his feet all day and really very much a high level chef within our area. So I'd be curious just to gain some initial thoughts or insights with all those factors in play. I'm not sure, Jack or Jens, if you have any thoughts. Ali, if you want to weigh in.
I guess we might have lost Jens. I conked out on the early presentation, but I guess from your fill-in that that you're predominantly concerned about biceps weakness. And I'll tell you the truth, I would have this guy evaluated by a neurologist because it doesn't really compute. He's got severe right-sided foraminal narrowing at C4-5, but his major pathology is at multiple at other places and multiple levels. His cord signal looks good everywhere. So I would just worry that you don't want to miss the boat on some other neuro degenerative disorder rather than or brachial plexopathy or something other than cervical spine pathology based on this imaging.
I always exceedingly reasonable, and I will tell you, the select cut that we had.
And I think Rick Iyer's on. Rick, you want to pop in?
Yeah, Dave, did he have any pain, or was it just the weakness primarily?
Good question. Kind of a bit of pain, kind of dermatomally in that C6 distribution. Really, is 5-6 disc there. We're kind of looking at that foraminal stenosis with maybe some congenital stenosis throughout, worse at 3-4. So a fair amount of pain, but this guy isn't one to kind of complain about those types of things. Really, the reason he's coming in is because he's weak now and can't do his job.
Well, unfortunately, you showed the picture of what you did, but I mean, I like what you did. I'm all about trying to preserve his motion rather than doing multiple level fusion. So I think, if you can do enough decompression posteriorly and do the foraminotomy at 5-6, which you can if you do that. So, and then open up the 3-4 level where he's severely stenotic. So.
Yeah, I think, and maybe I'll propose this question. I find, and I have concerns about isolated anterior-based approaches in the congenitally stenotic patient. In my hands, again, from the degree of space available for the canal, I think it's a point of discussion that, comes up. Now, obviously, if someone has foraminal disease at a single level, if you can do an isolated anterior approach to really out that foramina and you're not worried about the long-standing picture of myelopathy or something along those lines, I think obviously a different case. But for me, the case of concern is someone that has profound weakness that I feel like I should do a posterior-based approach on to open up the space available for their canal. It's just in my hands, I find that I'm not quite as good at a foraminotomy or posterior-based decompression for an isolated nerve root when patients are significantly weak. I think it's, obviously a very reasonable treatment strategy, especially if they have adequate foraminal height and, maybe you really take down that joint. But for me, in the setting of this gentleman's weakness and his congenital stenosis, I decided to do both an anterior and posterior based approach to really make sure we cleaned out that foramina. And again, so we went forward with a disc arthroplasty at that 5-6 level to really clean out that right side foraminal stenosis at the 5-6 level, and then a laminoplasty to really open up that congenital stenosis. So,
Dave, what do you think the acute what do you think the acute event was? I mean, what triggered such a sudden presentation?
Again, I think that 5-6. I think he must have had some degree of acute disc herniation there, and that foramina that really just, in the congenitally stenotic patient just pushed that nerve root over the edge and really resulted in his weakness to that extent. And so again, he's very mindful, very thoughtful of his symptoms, and from my standpoint, obviously, his insight in regards to, hey, I've been dealing with this underlying chronic issue for an extended period of time, but this is new and this is really concerning to me.
But not a lot of
Davis is asking if was an EMG preoperatively.
Yeah, there was an EMG done. It showed a 5/6 radiculopathy.
But you said that Rick asked the question about pain, that he did not have a lot of pain, that it was mostly weakness and atrophy.
Yeah, he certainly had. I think his atrophy was a little bit more limited, but from a pain standpoint, there, but really not his biggest concern. I think this is a guy that pain's not going to be a driving force for him per se.
Right. But I think, the board's answer for painless atrophy is usually not radiculopathy.
I think that's one of the most frustrating things we treat is painless weakness, right? And in my hands, oftentimes that's non-operative treatment, unfortunately. But again, Ali, I'd be curious on your thoughts. The congenitally stenotic patient, is there one that you would consider appropriate for an anterior-based approach, especially if it's at multiple levels, or is that something you're predominantly treating posteriorly?
Not usually. I am a proponent of posterior foraminotomies, but I do think in general anterior approaches and restoring some height is better to decompress the nerves. This case, I mean, and I think we talked about this before. Diagnostically, very challenging. I know you put a lot of thought into this too, and did a thorough workup. But the acuity of it, the fact that multiple nerve root involvements based on the exam, all the way from C5 down to C8, multi-level foraminal narrowing. He had central stenosis at 3-4 with a calcified appearance of a disc. So, I mean, certainly doesn't explain the acuity or the unilateral nature of it. A lot of thought went into this, but I would have done something probably very similar. I would have considered, I mean, if, after an EMG and probable neurology consultation, maybe just a posterior decompression, maybe a multi-level foraminotomy to start with an ACD or a disc replacement as a backup. I also was hoping that, to get some discussion on the timing of an acute weakness, particularly at C5, because it's something we see from time to time. Is it something you 3 out of 5 pretty sudden weakness in the bicep? You've considered it's 4-5 or 5-6. You have pathology. Is that something you treat right away, or is there any room for conservative treatment first?
Yeah, I think a lot depends on patient factors themselves. If someone comes in and they're 2 weeks into some right deltoid weakness, I think very reasonable based on who they are, what they do, to monitor that for a period of time. When it starts getting closer to 3 months, 6 months out, that's kind of, Jack, what you mentioned about painless weakness. If someone is 6 months out with painless weakness, that's a real discussion that you have with them about what you can expect with surgery. And again, from my standpoint, I'm very hesitant to offer someone optimistic news that if they're 6 months out and they're 2 out of 5 in their bicep, that any kind of surgical intervention is going to improve that. I think we probably all have different sentiments about what we would want to do if it was ourselves. But in this setting, truth be told, again, this guy really, and again, presenting it because it's a little bit unique and a little bit different. But a good historian in relation to maybe some of these chronic myelopathy complaints with really what sounds like an acute 5-6 disc pushing on that 6 nerve root and resulting in his weakness. I don't know, Jack. Do you have, if someone's 6 months out and they're 2 out of 5 in their right deltoid, but they're totally pain free, and say they're a tradesman and they're someone that's very active, doing a lot of overwork or overhead work, is that someone that you still offer an operation to?
Well, again, I think, you want to rule out, something else, ALS or some other primary disease. But, if you think it's chronic radiculopathy that's either been overlooked, neglected, or undertreated, you just have to hang a lot of crepe. You tell them that, it's probably appropriate to decompress it, but that they should anticipate a very prolonged recovery if they're going to get a recovery.
And Dave, in the comments, a good question is why a laminectomy at 3 instead of a laminoplasty there?
It's a good question. I go back and forth. There's a great paper that was written on. I don't do it this way, but some people actually place their laminoplasties in Gardner-Wells tongs, and then once they lift 3, take them through a range of motion and see if the C2 lifted spinous process the C3 spinous process abuts the C2 spinous process, which potentially can be, a source of pain post-operatively. I think, I use more kind of intraoperative judgment. And in this case, I thought that, when we lifted C3, it was dead smack right on C2. And I worry about kind of having some pain with extension. So in that case, typically I will do a C3 laminectomy. I don't necessarily routinely do that. It's kind of based on a case by case basis. But I think, a great study that looked into that in relation to taking them through a full range of motion with Gardner-Wells tongs once you completed your construct.
Dave, so will you do a doma osteotomy if not?
I will typically lift C3. I'll do a laminoplasty on C3.
Okay.
And Dave, how about which side to open? Do you open the symptomatic side? Do you do a formal foraminotomy also? Or do you buy the statistics that show it doesn't matter which side you open?
Typically, I do go to the symptomatic side, Jack. It's just, clinical gestalt. Sometimes I will look and see, I'll take a parasagittal cut of the lateral masses and see if there's one that, just looks like it's going to be easier to dock my plates on. But typically I will go on the symptomatic side. And if I'm doing foraminotomies, typically I will do that first before I go forward with the hinge and the trough. I don't know. Does anyone else have always go from the same side? Or again, I typically go from the side of the patient's biggest complaint, but obviously that hasn't been teased out as something that really has evidence to support.
And Dave, in this particular case, did you do much more of a foraminotomy at 5'6", or did you feel you got an adequate foraminotomy with your anterior?
Yeah, I kind of, did belt and suspenders. So I did do a foraminotomy at this level, just again, based on the concern of his weakness. I really wanted to make sure that we were cleared out, and it felt pretty good about the disc arthroplasty, but, we were there, and it really doesn't add too much to the morbidity or the time of surgery. So, did a foraminotomy there as well.
Yeah, I would have done the same.
So did the guy get his strength back and muscle mass? And what was the time course?
Yeah, I think we actually just saw him at 3 months. I think, Matt, this is a case that, I think we saw last week. And yeah, he's getting there. He's certainly anti-gravity now. I think he's pretty pleased, at least from that standpoint. Frustrating to me, this guy got back to work 4 days after the surgery, which, begs the question whether or not how compliant he is. But yeah, I think, hopefully going in the right direction. So only time will tell. But, he's anti-gravity now. He's happy. He's back at work from that standpoint.
Yeah, I don't know how old you are, but whether you did pre-plate laminoplasties, but I know Rick and I did, and the plates have made a dramatic difference in how patients do post-op, because you don't have to immobilize them, you can move them, and they're protected when they do go back to work 4 days. Because in the pre-days, I had one patient who just, spit their struts out because they went back and did stuff we told them not to do.
Yeah, I agree. I think there's great literature on how immobilizing these patients really leads to increased, pain, stiffness, those kind of things. So I typically offer them a soft collar for comfort, but typically try and get them out of that pretty darn quickly.
Yep. Nice case. Well thought out.
Let's see. So I'll go ahead and transition. Gabby, if you don't mind, we'll get you lined up here for a quick change of pace here. This is obviously going in a little bit different of a direction, but certainly a very unique case that I'm glad was in the skilled hands of Dr. Ozturk and not my own.
Thank you, Dr. Casper. So this is sort of a case of a deformity with acute myelopathy. So a 69-year-old male, he had a past medical history of opioid use. He was on methadone, HIV, asthma, prior gunshot wounds. And he had been seen previously by neurosurgery for his cervical deformity, which was basically just causing him some pain, and he did not want any surgery for it when he was seen in the past. But he came to the ED, presented to our service after several recent falls, and then a few weeks of bilateral upper extremity, lower extremity paresthesias, some myelopathic symptoms, urinary retention. 1 week prior, he had an episode of bowel incontinence, and then the day prior, he developed left upper and lower weakness and inability to ambulate. So his neurological examination in the ED was really notable for left upper and lower weakness. The delt was 4, so his biceps and triceps, and then lower extremity, knee extension, hip flexion was also weak. He had decreased sensation on the left side as well, in the upper and lower with some hyperreflexia, although no clonus and normal rectal tone. So these were his CT scans, so clearly long-standing cervical deformity, both coronally and sagittally, a lot of degenerative changes. And then we also got x-rays of him. You can just so that you appreciate the coronal deformity as well on the right-hand side. And then there we go. His preoperative x-rays were notable for a cervical mandibular angle of 35 degrees, that should be 0 for reference, and a Cobb angle that was 60 degrees instead of the normal 20 to 35. So our thinking about this case, or any really cervical deformity or any deformity in general, is first, is this something that's rigid? Is it fixed? Is it already fused? And if it is flexible, like how flexible is it? So in this case, this is a rigid deformity. It's obviously reinforced with ligaments and soft tissue, but it's not something that's fixed. So you expect to find some correction with traction. And then, in the case of cervical kyphosis, which this patient did have, you basically are buying them a front back approach. So one of the things that we think about is first doing traction to really be able to first get into the anterior space in the spine. And then for all of these deformities, you really want a long segment fusion to be able to make that correction and to keep it.
Gabby, if you don't mind, I'd like to pick Dr. Oster's brain here for a second. Ali, I've heard you mention before, when patients come in with acute pathology, the goal truly is to address their underlying issue and get them back on their feet and hopefully set them up for a potential deformity correction in the future. Obviously, this is a pretty unique case because the gentleman developed pretty rapid decline. But the issue in relation to treating something like that in this setting is that even a possibility to address his underlying myelopathy attributed to this drastic deformity? Is that even something that's on the table, or do you feel you have to tackle the deformity in this setting?
Yeah, I mean, it's a good question, Dave, and you're right. There's almost no such thing as a urgent correction of what's a chronic deformity. Obviously, things like PJK and so forth can present with myelopathy, that those happen acutely, but this is a chronic deformity that presented with myelopathy. It's possible, Gabby, I don't know if you have the MRI coming up. I don't think that doing just a LAMI in the setting of a severe kyphosis would necessarily be beneficial. And if there's ever a case where I think treating a deformity would be beneficial to the myelopathy, it's this one. So it's not a bad thought. Maybe just do a LAMI, see how he does, then bring him back for the deformity. But I don't think in this unique case that it would be the best option. I'd be curious to hear others' thoughts, though. It's a good point.
Gabby, do you mind going back to the just the preoperative X-rays there?
Was he neurologically improving as over that week that he was in Gardner-Wells traction?
I couldn't get enough to test. He was kind of, he wasn't tolerating it too well. I mean, we did 2 days. I mean, we didn't pick up a profound improvement in it. You can see that, you're absolutely right, but not enough for me to definitively say. And then someone asked, did we consider a preoperative PEG? No, we considered a postoperative PEG. I wish we considered a preoperative PEG in it. But we'll get to the post.
Yeah, I think that a very good insight with that question. Obviously,
very
this
good insight. Yeah.
Developed over time, right? And you imagine the shortening of the esophagus that comes with that fixed kyphosis. But I agree with you, Ali. Jack, I'd be curious to get your thoughts. In someone that has this kind of draping of the cord over this fixed deformity, I just don't see a way in which you can not address the underlying, massive issue in the room when it comes to how you're going to.
Yeah, I mean, it's the same way, like we get that on our boards a lot. Like if there's a calcified thoracic disc, we don't where there's kyphosis, we don't either you have to remove a ventral offending agent or you have to fix the kyphosis when and if appropriate. So.
Right, because it's the progressive kyphosis. No matter how micro it's occurring, that's the primary mover for this. So you've got to address that.
Did you
I think
consider getting another CT scan once you got that correction on 11.1, or through the navigation figured you just would get it then? Because you couldn't even read that original CT with the deformity.
Yeah, that's right. Yeah, no, I didn't get another CAT scan. Yeah, the CAT scan was hard to interpret, but what we could make out when you scroll through, and what we're obviously concerned about, is whether there were any fused joints where we could put screws and so forth. But if you scroll through it slowly, it looked okay, and none of the joints looked fused posteriorly. So
I think what's interesting, and I'd be curious your thoughts, Ali. My experience with traction is one, and the fellows in residence know, this is a painful process, right? No matter what you tell the patient, you tell them, I'm going to hang you in traction for the next 3 to 4 days, they are not going to be happy about it. And the other person that's not happy is the hospital administrator. When you say you got to keep them in the hospital for 4 days in traction prior to an operation, and they're worried about length of stay. So I applaud you. It's an poorly tolerated intervention from multiple ends, but clearly it's something that I think really adds to your overall correction. And I think we're fortunate.
Yeah, I mean, I don't. You're right there. I don't do it necessarily lightly, but in this case, it just accepts no substitutes. I think A, it just makes the anterior access easier, but B, just loosens up all those, soft tissue ligamentous things. Even in a very rigid and fixed spine, I'm always amazed at what you can get. So it's a very effective thing, but you're right. People don't love it, and God knows I'm not sure I could tolerate it for a few days, but
I'll
I
tell
think
you,
Sig Bervin might be on the line. Sig, do you have anything to add? I hate to put him on the spot. He may be looking away. Oh, well, sorry to interrupt.
We're fortunate we overlap a little bit with the Shriners Hospital in Philadelphia, and I'll tell you, they hang kids in halo traction for a month, and the levels that they save and the corrections that they're able to get, it's just it's unbelievable. So I think obviously this is a very powerful tool.
Yeah, and that's certainly a Rancho experience, especially in the older days. Even putting, halo wheelchair sitting halo traction for a week at a time or longer to straighten kids out a little bit before you ultimately fixed them. So it's a classic treatment. It's just kind of fallen out of favor with the instrumentation we have now. But there are cases where it's a much safer way to proceed.
Yeah, I don't see how you could have done it without having the traction. And Ali, what do you think about C1-2? Does he have an odontoid fracture on the 11.1 picture?
No, he didn't. I wish we could scroll through the CAT scan. I thought I could preserve occiput down to C2, but you're absolutely right. You have to scroll very carefully through, especially the coronal cuts. Look at the OC, the occipital joint and the atlantoaxial joint. So, but I thought we could avoid going all the way up.
So our plan was initially to do a C3 to 5 ACDF, and then C3 to 6 laminectomy, and then C2 to T2 posterior fusion. We ended up having to do a C5 corpectomy just because the C5 vertebrae was so unstable intraoperatively. So these are the post-op scans. You can see sort of the sets on either side, and then the midline cut. And then I'll show the x-rays as well. These are the coronals. And then here's our post-op x-ray. So we were able to get a correction of 12 degrees for the Cobb angle, and then the cervical mandibular got down to 30. So definitely improved overall from where he started. And then post-operatively, well, I'm sure we'll come
Yeah,
back
would
to
you
that.
mind just taking us through kind of the anterior part of the case? Were you there for this case?
I was not.
Okay.
Yeah, no,
How did that go? Yeah.
So fine. The plan was to do a C3 to a 3-level ACD. I actually like doing multi-level ACDs better than corpectomies in these cervical kyphosis cases. It just gives you more end plates to work with. 3-4 went fine, and then when we got to 4-5, the 5 vertebral body was so mobile. It was clear to me that I needed to corpectomize it. So we converted that to a corpectomy, but I was pretty satisfied with the amount of lordosis and support we could get anteriorly. What I didn't appreciate actually on this was how sclerotic his bones were from 3 to 6, that it made anterior instrumentation difficult. Not even an awl would penetrate it. And I just didn't feel comfortable pushing down so hard on an otherwise pretty sensitive spinal cord, because I was tapping with a mallet to get anything into that bone, and it just wouldn't go through. I felt fine leaving it uninstrumented. I mean, that's the cage was expandable, everything was very firm, and obviously I was going to get plenty of fixation in the back. I would have liked a little more anterior fixation, but that aspect of it was unanticipated. I don't think I've ever had that much trouble getting a screw into sclerotic bone before.
Hey, this
How
is
was the
Jens.
exposure? Oh, go ahead, Jens. We've been
Two
waiting for
thoughts.
you.
I just scrub in quickly. This looks beautiful in the final reconstruction, and these are super hard cases. So one observation and then a technical question. So the anterior unprotected titanium cage, I had done a couple of those in the past in my way past in UW. And our ENT surgeons did not like that because they say that our esophagus as human beings is like an octopus. It kind of feels around, pokes around, and it'll attach itself to any crevices or stuff that it likes. So I've actually I know of 2 patients where they had to do a pharyngectomy. Now, these are not these cylindrical kind of semi-solid ones. These were the era of the Harms type cages where they have serrations in the front. But I looked in on one and I was horrified. I mean, this is a beautifully placed cage, and 3 years later, the patient had weird swallowing difficulties, and they basically showed me how the esophagus had permeated literally into the walls of the cage. So they told me, and from there I got this mandate. I'm just using fibula allografts in the front if I can at all help it, or I put a plate on it just as a shield against the esophagus. I just wanted to share that story. And I don't know how many other people have seen that or heard that. We never wrote it up. It's just one of those things. So I don't know whether that's a concern for you or not, but in the longer
Yeah, I mean, no, thank you for sharing that. It's this patient had postoperative dysphagia. He needed a peg, but I saw him a few weeks ago and he had it removed. He's swallowing fine now. In general, I don't like anterior. I always instrument the cages from the front, even if it's so I wasn't necessarily happy with this, and I would have liked to have at least put those cages can accept screws through it, but like I said, the amount of pressure I had to put down to try to penetrate that bone was making me uncomfortable, because our signals were a bit tenuous also, and his spinal cord was a bit frail. That's a good point, and yeah, I hadn't thought about it. I hope it doesn't happen to him, but we'll have to see, I guess.
Ollie, how was the exposure? Did you do this with an ENT guy, or
I wanted to do it with an ENT, but it wasn't available that day. I had to do it myself. It wasn't bad. I don't remember exactly. I don't remember it to be a huge problem. But I would have preferred an ENT in this sort of case for sure.
So
You
what
kept him in
case?
traction.
Yeah, talk to us about the C2 fixation. So I see different C2 screws that do with C2.
I know it's the one black eye, one of the laminar surfaces. He didn't have good pedicles, unfortunately, so I went with laminar screws, and then one of the lamina cracked off. I just couldn't get both of them in. I was pretty annoyed about it, and I said, all right, well, hopefully with the anterior support and we'll be okay. But I wasn't happy about that part.
Yeah, no worries. No, thanks for sharing that. No, I just saw some asymmetry there. And I think that's so important to recognize vertebral artery anomalies and have bailout options, and translaminar screws are great and hugely important. The one thing that I sometimes do in osteoporotic patients, I put sublaminar cables around and then wrap those around the rods in addition to the screws, just to have belts and suspenders more or less, because that's such a critical fixation. I applaud you for not going to the occiput. Most surgeons who have gone to the occiput, it's very disabling to do that. So sparing the craniocervical junction for motion is really a big deal. So kudos to you for doing that.
Thank you.
So just to finish out, so he felt better after surgery. His left upper improved in strength to 4+ out of 5, 5 out of 5 everywhere else. And he left acute rehab post-op day 16. And as Dr. Ali said, he's doing well as far as the dysphagia is concerned now post-operatively too.
Great case, great result.
Yeah, thanks so much, Gabby. That is, again, that's when that walks into your office, or I joked with Ali, I said only he would get, as a deformity surgeon, that type of call case, that came into the emergency department on call. And of course they have that significant underlying deformity. So that's the curse of being the deformity surgeon, Ali.
And Dave and Ali, if I may, so beautiful handle, if I may add a negative prognostic sign for patient outcomes to the whole equation, and that is adentitia, patients who have no teeth. This is a classic adentitia patient. Everything, their healing outlook, their pathologies, everything just escalates to a different level. We should have a difficulty escalator for our CPT reimbursements for treating adentitia patients.
Or you could just use number of teeth.
All right, thanks everyone. Peter, do you mind taking us through our last case here?
Sure. Thank you for having me, everyone. All right. So this is a 75-year-old who presented to our office. She had a history of multiple prior cervical surgeries. Her main complaints were neck pain and also difficulty looking upward. So bear with me for a while because I have some few slides because she has a pretty extensive history, but fortunately she was able to bring her films and I was able to upload them. So she initially presented to an outside provider for neck pain, left-sided radiculopathy. She does have a history of prior C5-6 non-instrumented fusion done in 1990. And after seeing that provider, she was planned for a C4 to 7 hemilaminectomy and posterior instrumented fusion in 2021. So this was her post-op films. Unfortunately, she developed an infection, which culture showed MSSA. She was placed on antibiotics, and over a course of a couple of months, she completed her antibiotic course, and also reported improvement in her radicular symptoms, pretty much completely gone compared to pre-op. However, she did complain of continued neck pain, so she was indicated for a hardware removal in mid-2022. She underwent removal of hardware in 2022, and reportedly afterwards, she did have some resolution of her neck pain, and also continued resolution of her radicular symptoms. However, in early 2023, she returned for follow-up. This time, however, her neck pain has worsened. She complained of difficulty holding her head up. These are x-rays at that time. So she was indicated for a revision surgery. The plan for that surgery was C2 to T3 posterior spinal fusion with a couple of posterior column osteotomies and also plastic surgery assistance for paraspinal muscle flaps. Fortunately, she developed another surgical site infection with MRI showing T1 and 3 osteodiscitis. Subsequently was placed on chronic antibiotics. And even after that, she continued to develop worsening interscapular pain, difficulty holding her head up, especially when standing. And those are her x-rays after that construct was placed. And then this is the time when she presents to us with these x-rays, presenting with worsening kyphosis, difficulty with horizontal gaze, pain noticeably when standing up. These are her first x-rays in our office, showing a significant loss of cervical kyphosis with significant T1 slope, C2, C7, SV of 6.5 centimeters, and a T1 slope minus cervical lordosis of 45 degrees, and a C2, T4 kyphosis of approximately 50 degrees.
So Peter, let me stop you there, Jens or Jack or Sig. This is a lady comes into your office. She's had 4+ surgeries by an outside provider. She was told at her most recent follow-up with them that concern was that if any subsequent surgery happened, they wouldn't be able to close the wound. She's on chronic suppressive antibiotics. And she's left with this picture. So, obviously this is someone, the chronic problem is she's likely chronically infected, never cleared, and now really developing kind of some distal junctional kyphosis. So she's getting this acute problem in the setting of this kind of chronic indolent infection. Obviously, this is one of those you have set aside a 15-minute new patient slot in your clinic, and this walks in, and all of a sudden you say, well, we're going to need a little bit more time than that. But any initial thoughts in regards to this?
This would have been,
Dave,
Jens?
this
go ahead.
Let me tap on Sig. Sig, are you live in San Francisco? Do you want to? So first of all, when we see these wound infections, they're usually distal, and I can literally predict her clinical picture, which is that of trapezial winging, the delta sign, and highly protuberant spinous processes. And a CT scan would show us radiolucent screws. So this is a sequela of a long fusion with a non-union and a kyphosis, and trying to cover the soft tissues over that is near impossible. So for me, I'll just wing it here before Sig can go live. The answer here is to do a posterior hard removal for me first, then an anterior, and I have to study the images more. Anterior column release, and if possible, multi-level ACDs. I like and totally agree with what Ali said. I would not instrument it. I would do a soft, meaning allograft fusion over multiple levels, maybe a corpectomy at that weird hyperstatic area. And then do a posterior reinstrumentation in full lordosis and do a nice trapezial advancement, flap and closure. But the patient has to be in lordosis for this to succeed. Thoughts?
Do you have CAT scans you can share with us?
Yeah, I have a few select slides on the with CAT scans. Let's see. Just go over exam really quick, but her prior incision was healed. She did have diffuse reflexes throughout and positive Hoffman's bilaterally. And as mentioned, she does have difficulty with horizontal gaze. However, the deformity was passively correctable with extension when she was standing up. So here's some select slides, mostly at the T2 and T3 levels, showing Dr. Chapman predicted tons of lucencies around the screws and haloing, tons of osteolysis at those levels as well. And also there's a pseudarthrosis at T1 too. So complete junctional failure there. Some select sagittal cuts and also axial cuts. Not a significant amount of stenosis, surprisingly, in her upper spine. So this is our surgical plan. Coordination with ID in terms of chronic antibiotic coverage. At the time, I believe she was on chronic IV ANSEF. and also coordination with plastic surgery for post-op wound closure, given her previous paraspinal muscle flaps, and also potential difficulty with revision surgery here. Plan for multi-vector cervical traction intra-op, and possible revision or exchange of the posterior cervical thoracic hardware given the chronic infection. Plan to fuse down to T10 with the pedicle subtraction osteotomy at T3, along with multi-level posterior column osteotomies.
Jens, I think you make a very good point there. When you were mentioning removal of posterior hardware and then anterior based approach, were you planning to remove the posterior hardware, close the wound, and see if the infection could clear post-operatively, or were you planning doing a removal, anterior, and then posterior based approach all in one setting?
So this is a multifactorial decision. Nutrition matters, wound inspection matters. You can obviously stage this surgery, taking the hardware out first, debriding it, doing antibiotic beads in there, getting some muscle flaps elevated to get a closure. Those are all possibilities. Dave Atterbury, a good friend, just asked where to stop caudally. This is again one of those open subjects, and this is why I wanted to pick on Sig Bourbon. He gave a great distal junction failure presentation with his team a couple of months ago, and he's going more and more radical. He's going to like L1 pretty commonly. I think T10 is a great choice. This is where the bone density discussion comes in. But to go back to the soft tissues, getting the posterior hardware out, cleaning everything up, and telling the patients may take several surgeries to kind of just get clean soft tissues back there, get the bone out. And this is where antibiotic beads and a temporary fascial closure are such a big deal. And then going for the full shebang, posterior hardware without rods, and then an anterior release and a genuine full anterior column reconstruction with allografts, and then turning the patient around and connecting rods on. Obviously, a dual core system would be much preferable in that setting. And this may be a very difficult surgery because, again, I didn't see the CTs in full detail. If some of the lateral masses are fused, you'll not get a pure anterior column release. So this is where the anterior-posterior surgery comes in. And I've spent 10 hours in these kind of cases where I put in posterior screws, resect the lateral masses. For instance, at C7, that's a great resection site. I've done it higher up also, and get a full release, and then come in anteriorly and do ACDFs at several levels, and maybe a corpectomy at that large glob level, and then go posteriorly and do the large rods.
Yeah, I think that's the very valuable input, and I think oftentimes, the idea of infection and how we treat it, whether it's one stage, whether it's as Dr. Chapman said, removal of hardware. I've been using more and more antibiotic beads in my practice for these types of cases that show up that have been chronically infected. But it's certainly a difficult decision, especially when we're factoring in, a patient that's had their neck closed 5 times already, and we're asking to put it through, potentially one, maybe multiple more wound closures, and I think that's where we really have to lean heavily on our plastic surgery colleagues. Anything routinely, Ali, that you're checking in these infection patients? Obviously, I think bone density is important, nutrition is important, all those kind of things. But anything else?
I think a preoperative visit to infectious disease and plastic surgery would be important here. Now, I mean, a little more imaging would have been helpful. It's hard to know, what the role of. I probably would have done something similar. I mean, I'd like to see a little more the standing films and the CAT scans, but I'd probably lean towards a 3-column posterior osteotomy. C2 down to, in terms of where to stop distally, depends on the standing films, but I've been preferring L2 when and if possible. Is that safe to do where we are in the course of the infection? I'd like a little bit of input. Like you said, this is where the infection bit of this is throwing me off a little, but I'd ideally like to do it in one stage, all posterior, 3 columns, as was suggested here.
But your posterior bone stock is terrible. That's your most multiply operated bed. So, unfortunately, I don't think Izzy Lieberman is on, but I know Izzy likes also taking out the hardware, restudying the spine without metal in the way, to help you plan. I think the better bone is anterior. It's a revision approach no matter where you're going, but I think you have a better chance of reconstruction, construct, and potential fusion anteriorly, even though you're going to have to go back posteriorly and do something, but there's just not a lot of good bone left in there. There's a lot more space than there is bone.
Mm-hmm, mm-hmm.
It's
Yeah,
a tough one.
And Ollie, speaking of the bone that's left, did you have to use pedicle screws because your lateral masses are, at least what we saw, they look trashed.
Yeah, I'd have to see this a little more closely, but
I think that's a great point. It's something that maybe I don't utilize as much as I should, but with navigation, obviously, subaxial cervical pedicle screws are on the table. Is there anyone that really routinely does those in the revision setting, or has made it more of a staple of their practice? I have not, but maybe I should certainly look into it more in relation to the utilization and navigation.
Izzy does, and he shows some very nice pictures of those. I do them occasionally on a select basis. First of all, C2, unless there's a crazy vertebral artery anatomy, is the key in a multi-segment patient like this to get really high quality bicortical screws, true pedicle screws. And then below that, it's a matter of question on anatomy planning. I do those semi-open. Not like Izzy with his robot, and I make a small laminotomy. I put a probe on there and I drill directly down. There's a beautiful video by Dr. Abumi on Vimeo, one of those old video collecting sites, and you can see him how he uses his drill, and I basically just imitate him, and he taught me how to do that. So I do it in a semi-open fashion, drilling towards a probe and going step by step. It's actually, once you do it, it's surprisingly easy. It's a truly gratifying purchase, but you don't need to put one down every level. I think the top C2 is the key, and then after that, 2 or 3 levels, and you have great rostral purchase. The whole rest of the action is how far do you go down and how good of a release, a 2 or 3 column release do you get to put that head back on the shoulders again to get the soft tissues to relax.
Any utility, and I've been doing this a little bit for patients with large SVAs and maybe some chin on chest deformities, third rod construct using translaminar screws in C2, and then maybe the upper thoracic spine.
My partner, Dr. Hart, was always a great fan of putting multi-rods in the top, and I have not done that. But if I've had very unstable patients, I don't want to mention the manufacturer, but there are manufacturers who now make thoracolumbar screws suitable for 5.5 rods, and they're like 16, 18, and 20 millimeters long. So you can actually put like nice quality pedicle screws in the top and have a thoracic rod basically run all the way down. So not even just a dual core rod, but a Genin 5.5 and or 6.0 rod. And I actually did one not too long ago in a salvage surgery, not dissimilar to this. And I just ran a rod all the way up to C2. So there are manufacturers out there now who have these kind of different hardware sets. I'm not a huge fan of multi-rods. I do it all the time in the thoracolumbar spine, but not in the cervical thoracic spine, just not seeing the need for it.
Great input.
These are some intraop fluoros of what was done. So intraoperatively, there's actually no purulence identified, but the T1, 2, and 3 screws are all taken out. The lateral mass screws at C2 to 7 were all found to be pretty solid, and there's a large sheet of fusion mass that connected everything. So instead of revising those screws, the rods were taken out and then connected with to the thoracic screws with a PSO at T3 and a bunch of PCOs running all the way down to T10. These are our first erect films. You can see her T1 slope improved significantly, as well as their C2 T4 kyphosis. And then her 1 month post-op visit demonstrates she's standing pretty well. Overall, she was doing pretty well. Unfortunately, I couldn't show the CBVA in the original films, but they were measured at negative 25 degrees, which has improved to -2 here.
Yeah, this is a tough case. This was done by one of my partners. And again, I think, all things created equal, the idea of having a little bit more lordosis through that subaxial cervical spine would be appealing. It sounds like exactly as you relayed, Jens, the individual was fused through the set joint posteriorly. So obviously that would involve a back front back where you're doing full facetectomies. And then obviously if you're fused out in the unsonance, drilling down the unsonance as well. And I think his concern was about the multiple approaches to the posterior cervical spine. And I think, our plastic surgery colleagues were concerned about having to go back and forth multiple times. So obviously these are challenging cases. And, I know he spent a lot of time with this patient and trying to optimize them and put the best foot forward to provide them with hopefully a stable foundation to avoid further surgery. But obviously the jury's still out on where this will end up.
David, how far out is she now?
Peter, do you know?
Yeah, she's about 1 month out, maybe a little bit more, like 5 weeks at this time.
And I assume they'll keep her on suppressive antibiotics for a long, long time.
Yeah, she's on chronic, actually IV Ansef, according to the last ID note.
Yeah, I'm sure she's doing 6 weeks or 8 weeks of that. And then, yeah, I agree. This is a patient that she's on antibiotics for life for sure.
A really tough case, but beautiful result.
Yeah, if you can get this to heal, it's as close to a home run as you're ever going to get on a case like this.
Were you involved with this case, Peter?
No, I was not.
Curious. Do you know if any biologic was used?
No biologic. I think there was concern given the chronic infection. The only allograft that was used was autograft and allograft, like Kintelis chips.
Is anyone routinely using a specific biologic for these types of infections and taking iliac crest autograft? Anything that in the chronically infected patient they would do differently for this kind of individual?
No, but off-label use of BMP and declared as such might be a good idea on this patient. So, yeah, this is a nice salvage attempt all from posterior. Again, let's not forget we can do C7 subtraction pedicle osteotomies also, by the way. That's a very legitimate other goal. You have to basically be willing to take down the C7 pedicle and then drill out parts of the vertebral body, and with that you can achieve a better lordosis. So I'm still worried that this patient's hanging forwards a little bit. Any tips and tricks or observations on the soft tissue management on this patient, because that's again still going to be a tension zone there.
Yeah, I think that's obviously of concern. I think we're fortunate we have great plastic surgery colleagues. Obviously, implant size, implant location. Obviously, these are pedicle screws or tulipeds that you don't want to leave proud. Some companies obviously have their variation of their tulipeds, which can lend itself in more petite patients to a little bit lower profile construct. But yeah, I think a lot of times this is, you get the experts in there to do their work, and then you just sit back and pray. And traditionally, this patient's getting an incisional vacuum throughout their hospitalization. They're following up with them at a week, sometimes leaving two deep drains, two superficial drains, for a prolonged period of time. All those kind of tricks that hopefully they pull out to make sure that this heals.
Hey, man, I just saw this. Did you guys implant stuff in this gal today?
No.
Or did Christian bring this from another person?
Well, Dave and Ali, these were great cases. I think you got the result you wanted, which was a lot of discussion on things that are certainly not black and white. So thank you for sharing them with us. Everybody, get your CME. I think the number is 1262, and we really appreciate participation from our friends on the East Coast. And good luck with the rest of the snow.
Yes.
Thanks as always.
Thank you to our
Yeah,
friends.
thank you, Jens.
Great team. Good stuff.
Wonderful.
Thank you, everyone. Appreciate
Take care,
that.
guys.
All right.